So we're going to continue from here. Got my slides switched up. So we are on the active phase still. Okay, so as we progress, we're going to have accelerated dilation that's going to get to 6 centimeters or greater. Okay, you should be going about 1 centimeter per hour when you are in that active stage. If you're a first-time mom, maybe 1.5 centimeters per hour if it's your second baby. That baby, the contractions are going to be about every 2 to 3 minutes. And it's going to take 45, they're going to last about 45 to 60 seconds, sometimes longer. They're going to be moderate, increasing to strong. So we're going to give comfort measures. We're going to assess pain. We're going to assess the vaginal, do a vaginal exam to see the cervical opening. And we're only going to assess this as often as we need to. We used to assess every 2 hours, but no longer do we do that because of the risk of infection. We just do it as indicated. Indications that labor is progressing, you're going to see an increase in bloody show, restlessness, or the urge to push. So dilation, again, that nullipary, you're going to see about every 1 centimeter every hour if it's a second baby, or more, 1.5 centimeters every hour. So we want to do lots of position changes. You want to do, left lying, right lying. Left lying is the most common because we want to get baby off the vena cava. Do you want to do squatting? You can do high Fowlers, semi Fowlers, sitting position. Sitting position, our beds actually turn into kind of like a chair. I call it the throne. So you get a patient sitting up in high Fowlers, you drop the feet of the bed, and they're able to kind of sit in a squatting position. We do not have birthing chairs here, but there are things such as birthing chairs. We have birthing balls that they can sit on. We have peanut balls that go between the knees that actually help to open up that pelvic outlet and allow that baby to come through more sufficiently. Sometimes we do have to augment the labor, and this can be done by rupturing the water or giving oxytocin to help induce those contractions and make them stronger. So transition phase, yikes. So this is when we're still in stage 1, but we're at that transition phase. So this is that 8 to 10 centimeters. There's significant change going on. Mom's getting a little bit more anxious. She's restless. She's, fearful. Sometimes you'll see a change in the look in their eye. So it's not typically any longer than 3 hours for a first-time baby and maybe 1 hour for a second or more. Contractions are going to be about every 1.5 to 2 minutes, lasting 60 to 90 seconds. They're going to be very strong. What are we going to do as a nurse? Okay. We don't want to leave her alone unless she has someone there with her. We're going to focus on helping her to focus and relax. We want to let her rest as much as possible. If she doesn't labor epidural and she's not feeling anything, let her rest. She needs to be able to push that baby. We are the cheerleaders. Okay. We're going to help reinforce, make them feel better. And we're going to cheer them on as they're going through the labor process and then about to start pushing. We want to make sure they're breathing in through the nose, out through their mouth. We want to think about breathing techniques. We do not want them to hyperventilate, which is possible. And they're going to complain about tingling in their lips and their hands, and they're going to feel lightheaded if they are hyperventilating. So the second stage, which is the birth process. So dilation is complete. We're 10 centimeters. Okay. So what is the physiological law? Okay. This is a latent phase. So it's after the complete dilation and before that feeling to push. And sometimes we have people that get to complete and maybe that baby's still pretty high. So we will do what we call let them labor down. And that just allows that body to naturally get that baby moving down lower with each contraction rather than mom having to use all her effort to push. Descent of the fetal presenting part continues until it reaches that perineal floor. So again, we're letting her labor down. Then she's going to start to have that urge to push. Okay. The active pushing phase is going to occur. Baby's going to be pushing down. She's going to feel that urge. The head is descending into the perineum. As she begins to get to that perineum, or the head gets to that perineum, you're going to feel burning. Okay. You're going to hear it be called the ring of fire. Baby is about to come out. So usually the doctor is going to be on the floor. It doesn't mean they're going to be in the room with you as you're getting the baby to this point, and then we're going to call for the doctor and encourage the patient to kind of pant until he gets there to finish delivering the baby. So as a nurse, you're going to monitor heart tones, assess effectiveness of the pushing efforts, encourage and then direct the patient for more adequate pushing efforts, and revive the dad because sometimes they pass out. I always tell them, I'm like, if you feel lightheaded, make sure you sit down because I have one patient I'm caring for. I'm just going to leave you there. I'll make sure you're not bleeding, but then I'll leave you there and get you up whenever we're done doing what we're doing. So birth of the neonate. So episiotomies used to be very common. Okay, we do not do episiotomies very often anymore unless it's emergent. And there's two types. You have a medial lateral or your midline. So the midline is where you actually cut straight down between the vaginal wall and the rectum. The medial lateral is where you cut kind of angular between the vaginal wall and the rectum. And the idea behind the medial lateral is it's not going to tear down through the rectum and have like a 4th-degree laceration. And again, we only do this in high intense, risky, baby has to come out situations, okay? The fetal head has to be descending through the labor process. So we need that baby to keep moving down. Descent of the fetal head into the pelvis, and we're looking at the flexion of the fetus, making sure the head is appropriately flexed. There's going to be internal rotation occurring as that baby starts to come down if they are kind of tilted one way or the other. You're going to see external rotation as that head comes out. It's going to be facing down, but then you're going to notice that the body is actually coming out sideways, and that's that shoulder rotation as it comes through. Expulsion is after the external rotation occurs and the anterior shoulders meet undersurface of the symphysis pubis and slips all the way out, and the anterior shoulder comes next, and then the body will follow. I'm sorry, anterior shoulders next, posterior shoulder, we got to get both of them out, and then the body will follow. A shoulder dystocia is when the head is out, but the shoulders cannot pass under that bony prominence, and you are going to have to help. So this is called McRoberts maneuvers. So what you're going to have is a nurse on each side. They're going to pull those knees way back towards mom's ears, basically. And then you're going to have another nurse who is going to get up on top, and you're going to put pressure right above that pubic symphysis to help push that shoulder under, okay? There's a big risk for injury to baby with this, but it's better to have a broken clavicle in the baby than a dead baby. So it's very important that we do this if we have a head that's come out and we cannot get the shoulders out, and we have to act very, very fast. So after the baby is born, the head at least, okay, we're going to talk about what the steps are for baby, or for the doctor that you're going to see done. So the head's going to come out. You're going to see that the physician is going to feel around the head to see if there's a cord. If there is a cord, he's going to try to reduce it. So he's going to try to see if he can pull it up and around the baby's head. If he cannot, then sometimes he'll put 2 clamps on there and cut the cord and then finish delivering the baby. Sometimes mom's just pushing so fast that you don't even have that chance. So what you would do then, I was taught this by a midwife, is as that baby's coming out, you're going to kind of try to keep that head towards the perineum by delivering the body, keeping the head there and delivering the body underneath. You're going to suction and wipe the mouth while the head's still stuck out and nothing else. Once that body's out, you're going to dry and stimulate that baby, okay? Initially, always dry and stimulate, because stimulation is going to cause them to cry, which is going to allow oxygen to fill those alveoli and push that fluid out. You're going to clamp the cord with an umbilical clamp and then usually another instrument and cut between. You're going to assess again for Ava, our friend Ava, who's on every umbilical cord, as should be, 2 arteries and 1 vein. You're going to provide warmth to the baby, because we do not want to cause hypothermia, which could result in hypoglycemia, or hypoglycemia, which could result in hypothermia. They kind of both go together. You're going to see what time it is, and then we're going to assess an APGAR score at 1, 5, and 10 minutes. And we'll talk about this next week when we do the newborn. We are going to obtain a cord blood sample. Some hospitals check for baby's blood type. Others just look to see if there's any antibodies in baby's blood. It just depends on what the provider and the facility choose to do. So your third stage of labor is when you have a baby or have a placenta. You've had a baby, now you're having a placenta, and sometimes they think it's another baby coming out because it's such a big placenta. I've actually had patients state that the delivery of the placenta is almost worse than delivery of the baby. I don't know. I had an epidural with most of mine, so I don't know. The delivery of the infant has occurred. Now we're going to wait for the placenta. Usually it happens within 5 to 10 minutes, but our max time frame is 20 to 30 minutes. If we get to that point, then we are going to look at having the doctor do what's called a manual extraction. That's where they put their hand through the cervical awls into the uterine cavity and actually manually try to work that placenta off the uterine wall. Okay. We talked about the shiny Schultz and the dirty Duncan yesterday. You're going to inspect it for abnormalities. Okay. You're going to make sure that there's a whole placenta there and that there aren't pieces missing, and observe for any problems associated with lacerations to the perineum or the vagina. Whenever the placenta is delivered, the physician is going to say placenta, and this is your clue to go ahead and either add the Pitocin to her LR that's running or open up the Pitocin that's running for induction, if that's what she's having done, and put it at 999 or 500, depending on the patient. If it's a first-time mom, usually you can do 500 if you notice she's not bleeding a whole lot. If it's a second-time mom or greater, you're usually going to do open wide or 999 to allow her to get as much Pitocin as possible until that bleeding is under control. So here you're going to see pictures of lacerations. So in that third stage, the placental stage, is when the doctor is then going to assess for tears and going to fix the tears that are there. Okay. So in your first picture, you're going to see a first-degree perineal tear. So this is where the tissue between the vaginal opening and the rectum has torn just a little bit on the perineum. You can also have vaginal tears that are up in the vaginal canal themselves. A second-degree tear is where the perineum is torn and it goes down to close to that anal sphincter, to the muscle. Okay, it's gone through that mucosa. Third stage is where you have the anal sphincter and involvement of the muscle itself. Okay, we haven't gone all the way through the muscle, but it involves the anal sphincter and some anterior wall of that rectum. A fourth degree is pretty much the same as a third, but it has gone all the way through that wall of the muscle into that rectal tissue, and you basically have two holes that now have become one. So fourth stage, this is that first 1 to 2 hours after birth, the postpartum period, the initial postpartum period. This is following that delivery of the placenta and any repair. So our job as the nurse is we're going to clean up. We're going to apply ice to the perineum. We're going to monitor for bleeding. We're going to monitor vital signs. If they're stable, we can do every 15 minutes for the first 2 hours. We're going to palpate and massage that fundus every 15 minutes for 2 hours. If they did not receive Pitocin for whatever reason, we're going to do every 5 minutes for 2 hours. We're going to look at the bleeding, assess it, look at the color. Is there any blood clots with it? Do we note any odor? And we're going to try to make her feel comfortable. Okay. And we need to feed her. Okay. But our biggest thing in that first few hours is we're assessing amount of bleeding and making sure she's not uncomfortable. Okay, after listening to this, if you have any questions, please let me know. This is pretty basic labor and delivery. There are lots more details that I could give you, but it would just be a bunch of mumbo jumbo. Okay, so as we go along, we'll address questions and concerns and possible interventions as we have things arise in our lecture and our simulation. Have a good day.